Today we're going to talk about
mental illness
in pharmacy. Mental illness is a significant global issue that causes a great amount of suffering among individuals worldwide. Patients with mental health disorders experience social isolation, poor quality of life, and a higher rate of mortality. The incidence of mental health disorders has been growing exponentially in the United States, leaving 14% of the global disease burden being due to mental disorders. Both the United States and the World Health Organization stress the importance of treating patients in order to try to decrease the gradually increasing rates. The increase in mental health disorders is a huge issue, not only because of its exponential growth, but also because as the rate of mental disorders increases, the rate of physical illnesses also increases in the same patients. Mental health is often referred to as a global burden because of its cost. As of 2004, it was estimated that 16% of the nation's gross domestic product was spent on healthcare, and 6.2% of that was spent solely on patients with mental illness. It is important to keep in mind that these costs exclude the indirect costs of incarceration, homelessness, public benefits, and medical complications with medical disorders.
The World Health Organization estimates that globally 154 million people suffer from depression, 25 million from schizophrenia, 91 million from alcohol use disorders, and 15 million from drug use disorders. About 450 million people total suffer from mental health issues, and for every 1,000 of them, there's an average loss of 237 years of life. The Epidemiologic Catchment Area Study of 1978 found that 20% of United States interviewees had a diagnosable mental disorder in any given year, and the National Comorbidity Survey found that 21% of them had a single disorder, while 79% had a comorbid disorder. At-risk populations, such as minorities and those with lower socioeconomic status, are less likely to seek mental health care, giving them a poor prognosis once they're diagnosed. The most vulnerable are the dually eligible elderly, of which 38% of them have mental disorders, and the homeless, of which 26% have mental disorders.
Providing high-quality health care for persons with co-occurring disorders is exacerbated by a number of factors such as lifestyle issues, at-risk behaviors, service utilization, and barriers to care. Persons with co-occurring disorders often have more instances of premature death and higher rates of disability than those who don't have co-occurring disorders. In the United States, depression is the second leading cause of disability-adjusted life years in women, but the 10th leading cause in men. It is estimated that for every dollar invested in drug treatment, $7 are saved in health and social costs.
Historically, the organization, financing, and provision of alcohol, drug abuse, and mental health services in the United States have been complicated by a confusing assortment of uncoordinated public and private delivery systems. Multiple funding mechanisms have been parallel to general health services. The President's New Freedom Commission on the Mental Health Report from 2003 identified 6 goals. First, it framed mental health as an essential component of overall health and well-being. Second, it focused on outcomes of care to be consumer and family-focused. The next 3 goals addressed disparities of services, urged implementation of early screening, assessment, and referral to mental health services, and prioritized mental health services delivery and mental health services research initiatives. Finally, it urged the utilization of emergent information technology in mental health.
It is often thought that people who suffer with chronic mental illnesses have greater medication non-adherence than those with long-term medical or physical illnesses. The true reality is that those with chronic conditions do not take approximately 1/2 of the doses they are prescribed, regardless of what condition they have. The reasons for non-adherence in people with mental illnesses are very similar to those with chronic medical conditions, but with a few additions. Some common reasons for non-adherence are the lack of understanding of the severity or even the presence of the condition, forgetfulness, difficulty in paying for the medications, unstable housing and support systems, and the lack of access to care. It is important for pharmacists to try to address these adherence issues because it has been documented that improving the medication adherence of schizophrenia patients will decrease the rates of hospitalization. There have also been studies showing that greater patient counseling when dispensing antidepressant medications helped improve the patient's symptoms in a shorter period of time than those that had the usual care. Pharmacists need to build a relationship with a patient so that the patient feels in control of their treatment options, and the pharmacist needs to continue to provide complete counseling of the medications in order to promote adherence to the treatment plan.
Evidence-based practice is considered to be a practice or treatment that is supported by research that is published in clinical literature. This type of practice is the basis of the curriculum now offered by healthcare professions, schools, and colleges. Treatment guidelines that are developed for medical conditions can be evidence-based in nature, or they can be expert consensus guidelines. There is an important difference between evidence-based guidelines and expert consensus guidelines. This pharmacist is newly graduated from pharmacy school. He works at a pharmacy near a community mental health center, and many of the patients use his pharmacy. In pharmacy school, he learned much about how to treat mental illnesses, but not how to interact with mentally ill patients. He, as well as many of the technicians, have beliefs about mental illnesses that impact his ability to counsel patients well. On one occasion, DL, a 42-year-old female with chronic paranoid schizophrenia, comes in.
Hi Donna, how you doing today?
Fine, I'm a meds though.
Are these meds that you've been taking?
Yeah.
How have they been working for you?
Fine, they're fine.
I noticed that you have your tremors in your hands. You know this medication can cause tremors?
No, I didn't.
Alright, well you should contact your physician to see if you can switch your pills.
Okay.
Several days later, DL returned to pick up her new medication and thanks the pharmacist. Taking the step of encouraging DL caused her to make the effort to take care of herself.
Medicaid programs in the United States often utilize preferred drug lists in order to minimize cost. These PDLs have ongoing arguments, including the restriction of patients from certain medications. This issue often revolves around the issue of the increased cost of drug treatments for mental illnesses. The state of Indiana enacted a legislation known as the House Bill 1325, which allows the use of behavioral health drug treatments without restrictions as long as they manage to maintain cost-effective care for patients with mental illnesses.
There are many mental health promotion activities aimed at enhancing self-esteem and sense of well-being. Healthy People 2020 established 14 objectives in the categories of mental health status improvement, treatment expansion, and state activities, with a focus on depression. As behavioral health care changes, pharmacists and pharmacy students should keep in mind the following 4 topics: the medical home, the Employee Retirement Income Security Act, rural behavioral health, and legal and ethical issues.
In many treatment settings, a clinical psychiatric pharmacist plays a vital role. The clinical psychiatric pharmacist may function as part of a team or see patients on an individual basis under a scope of practice in collaboration with a psychiatrist. Because of the lack of psychiatric providers in many settings, the role of the clinical psychiatric pharmacist is expanding into undeserved areas of the population. Clinical psychiatric pharmacists are working with primary care physicians and physician extenders to improve mental health services. The pharmacist evaluates the screening responses and provides feedback to the physician to improve patient care. The community pharmacist is a professional who sees the patient on a routine basis for the medication refills, which means they are often the first person to understand if a patient is missing refills, suffering from side effects, or beginning to have symptoms of mental illness.
The concept of the medical home originally focused on children with special healthcare needs. Today, the concept of medical home is patient-centered, multifaceted source of personal primary healthcare. The healthcare reform bill emphasizes new patient care models such as the patient-centered medical homes. This includes pharmacists as part of any standard healthcare benefit package in the creation of accountable care organizations and a medical home demonstration program. This will increase the role of pharmacists in MTM services, patient outcomes, and symptoms tracking.
Pharmacists and changing pharmacy practice are a continual need in order to address the needs of people with mental illnesses and substance abuse disorders in rural areas. Studies have shown that 65% of patients have never discussed health issues with their pharmacist. In order to correct this, there will have to be a continual professional development because it was reported that rural pharmacists felt less prepared on patient care-related issues. The Indian Health Service is one group that tries to fix this problem by employing pharmacists to work in multidisciplinary teams in isolated areas of western part of the United States and Alaska. They reach approximately 1.5 million American Indians and Alaska Natives. In pharmacy, there are still a number of legal and ethical issues in the behavioral health services. One of the largest issues is the denial of insurance coverage. This is such an issue because of the mental health parity laws. A parity diagnosis is a diagnosis selected from a subset of psychiatric conditions eligible for coverage under the parity law. Providers were found to be selecting a parity diagnosis for patients in order to ensure insurance coverage for diagnosis and treatment. If a provider chose a non-parity diagnosis for a patient, there would be no insurance coverage. The choice between choosing a non-parity or parity diagnosis because of insurance-covered issues becomes an ethical issue. There are also important legal issues when it comes to the basic right of privacy. Patients need to be assured that confidentiality will be maintained unless they specifically requested sharing of information or the mental health professional believed the patient posed a clear danger to self or others. The Health Insurance Portability and Accountability Act even provides protection for the psychotherapy notes. Records must be kept separate from medical profiles and may not be transferred without consent. It is important that there is a continual protection of patient privacy for patients that are being treated for stigmatizing disorders.
Pharmacists learn to work with patients during their rotations and in practice, not during their education. The comfort level of pharmacists working with people with different disease states has been studied in clinical trials. These studies conclude that community pharmacists are more likely to counsel a person with cardiovascular disease than they are with a person of mental illness. Pharmacists are not only more comfortable with these patients in terms of their disease state, but also more comfortable with discussing the drug therapy of cardiovascular disorders. It seems clear that the further education of both healthcare professionals and the general public is necessary to reduce the stigma against people with mental illness.